together in 1993, and in 1993, we were talking about healthcare cost. And I hated the days that I was a provider negotiating, and I hated the days that I was the employer trying to provide health insurance for their employees. Because we talk about wearing a lot of different hats and being a little schizophrenic from time to time. Those were things that made me do that. But in 1996, early in my CEO career, family premiums were about 11% of median income. And folks were talking about that was too expensive. In 2011, family premiums were approaching 20% of median income. So obviously, in a 10-year period, 15-year period, we've seen premiums go up over 100%. And this is not an attack on insurers. In fact, we would not have made it as far as we made today without insurers supporting what we're trying to do. It is the fact that as healthcare costs go up, someone has to cover those costs. And it's all of us. Businesses have been complaining about cost ever since I can remember. According to the National Federation of Independent Businesses, since 1986, it has been cited as the #1 concern for small business. So access to affordable health care is nothing new. And currently small businesses do pay on average about 18% more than large businesses for health insurance. And that is despite the fact that large employers have seen premiums increase more than 113% in the past decade. So I think we all agree we have a problem. I think where we start to differ is how do we approach the problem. Three things have to go into play in order for true delivery system reform to work. The first one is consumer engagement. People have to understand what they're getting, what they're paying for, how much it costs them, or how much it's costing someone else. And that, in many ways, the work that we're doing in the marketplace and exchanges will do that. People will start to understand what's being covered in their policies, what they're responsible for paying, and it will be done so in a standardized approach and language and actual conditions. Because I think lots of our consumers get lost in co-pays and deductibles and cost sharing. So we're translating it into plain English. And we're only starting, obviously, with a few diagnoses, but I return that will be. The second thing we're doing is data sharing. CMS has been accused for years of being a non-transparent agency, an agency that held and controlled a lot of data and didn't share it. So we started to share, and we're going to continue to share and share more, because we believe for accountable care organizations and other multi-payer delivery system reforms to work, people have to see their data. They have to understand what's going on, and they have to make changes based on that data. So you'll see us starting to share more data and hopefully share at a price that's more reasonable. And the third is we believe everything has to be a multi-payer approach. We may talk about Medicaid expansion, we may talk about state employees, we may talk about private business, but in order for this to work, providers, insurers, the public, and government all have to come together and face this together. And part of what we've been doing, and I have an excellent medical officer, Dr. Patrick Conway, is we spent the last few years trying to align all of our quality incentives and make them simple to understand and more based on outcome and not so much based on process. The process should be up to each of you. The outcome is what we should hold you accountable for. And the good news with that is states are working with us, private payers are working with us, so we don't have multiple systems measuring multiple things, because we believe we have to have national standards, and we think that's important. Another area that we have worked with has to do with the Medicaid population, because I hear all the time, the Medicaid system is broken, the Medicaid system needs to be changed. And I would agree that the Medicaid system needs to be changed. And so we've started to do work in that area. We started to work with states, and I'll talk a little bit about Oregon State. Oregon's been interesting. They came to us with a Medicaid waiver and they said, we want to use the Medicaid waiver as the basis for how we change work statewide. And so we were like, that's fine. So tell us what you want. And so the first thing they want to do is reduce the rate of growth and their cost, okay? So they actually put in a target that they wanted to use. They wanted federal investment, which obviously we did. They wanted to be paid for outcomes and not for process. So they're in the process of actually paying Medicaid for outcomes and not for process. They wanted to be held accountable. And if it didn't work, they wanted to be responsible as opposed to the federal government being the only person who was responsible. And they wanted some flexibility. And the message I want to send there is that we are willing to work with any state Medicaid program with those kind of principles. So even though Medicaid may be a traditional program, we're in non-traditional times. And then they want to expand that to other payers. And so we actually did grant them recently so they can start to pull in their private insurers, their state employees, and make this a multi-payer approach, which I then really think starts to change impact statewide. And so we think that's important. So now I want to talk a little bit about employers and what I think is the good and bad for employers under our recent policies. I think the 80-20 rule is very important for small employers. I would say for most large employers, but not all, they were already in compliance with the 80-20 rule, meaning that at least 80% of their premium was going to health care. Some large employers have gotten their 80-20 up to like 95-5. So, but for small employers, sometimes 40% of their premium was going to marketing and administrative costs. And so there's some protections to try to make sure that whatever premium you're paying is actually going for health care. I think that's a good thing. The second is this covering dependents up to age 26. And statistically, although there are some folks who would argue, there's some folks unfortunately who have argued this point with me, statistically that should be 0.1 or 0.2% of 1% of the premium. But what it did do is it enabled a lot of young Americans to get to continue on policies at a time when the recession was at its peak, and many of us as parents were watching children go uncovered and then have problems either with accident or illness or injury. So there are other things that I think folks need to understand about employers. If you are a small employer, meaning if you have less than 50 employees, you are not required to have health insurance. We want you to have health insurance, and part of the principles that we are enacting in January of 2014 are designed to encourage you to have health insurance. But if you decide you don't want health insurance, you're not required to have it, and you don't pay a penalty. The penalties apply to employers above 50. And yes, I know that there are employers who are borderline trying to make decisions, and yes, the 30-hour rule, and I actually saw today that Congress substituted a provision to move it from 30 hours to 40 hours, and we'll see what happens with that. So there's a lot of discussion about the 30-hour rule, and does it have unintended consequences? So those are the kind of changes that we'll have to take a look at as we go forward. But as a large employer, you should also be seeing something else. You should be seeing the smallest premium increases you've seen in a long time. Because the work that's going on inside CMS doesn't just stay with Medicare. It transcends across all issuers, all employers. So you should be picking up some of the benefits of the changes that we're making and the changes in cost trend. And despite all the concerns about large employers dropping insurance, and I know that was a conversation earlier today, what we saw in Massachusetts, and yes, this is Massachusetts, and the country is not all like Massachusetts, I get that, is that they actually increased employer-covered insurance from 70 to 77%. So we'll have to see what happens. But at the same time, unemployment in Massachusetts dropped faster than the national rate after the law. So let me turn to small business for a moment and talk about what's in it for small business. As I said, if you're less than 50 employees, you're exempted from the law. That today represents 5.8 million out of 6 million total firms in the country. So 5.8 out of 6 million are exempted from the law if they choose to be. The goal of small employers was to create a level playing field for small businesses, applying the same rules that are available to large employers today. And I can tell you, I've been a member of the Virginia Chamber of Commerce. I was on the Chesterfield Business Council. And in 1993, we were talking about this. And and how to put together small businesses to give them the leverage to buy, affordable rates. And that is what this is attempting to do. It prohibits small businesses from being charged higher premiums based on the health status of employees. And that, ladies and gentlemen, is a game changer. That's changing the rules of healthcare, or the rules of insurance as we know it today. It eliminates lifetime limits and it requires certain minimum. That's also a game changer. And that is what I think is important for us to remember. We're actually changing how we're approaching who gets insurance and what they're required to pay. And I'll tell you, my youngest daughter, who's 26, is type 1 diabetic. And I had to try to price her in the private market because she was only eligible for the private market. And it was sobering. And it's relieving to me at a personal level to know that as of January 1, 2014, she's entitled to the same benefits as anyone else. So elimination of pre-existing conditions is a reason to charge more, goes away or is moderated. And that's important. And more importantly, people cannot be held out of the insurance market due to a pre-existing condition. There will be standard policies, so less surprises. I'm not saying there won't be any surprises because we will learn as we go. But the 10 essential health benefits that we talk about, that sets a level playing field for what insurance is and what it is not. Let me talk for a minute about what happens over the next couple of months with the exchanges in the marketplace, and then I'll be quiet. Effective October 1, folks will have the ability in every state to sign up and understand that they are available for tax credits. So what happens between now and October 1? Beginning, I think you'll see it as early as, well, you can see it in some states as early as this week. Some of the state-based exchanges have already started TV and print ads. We're spending between July and September trying to just educate people about what is coming, what's available to them, what are the things we're trying to accomplish. Beginning in September, we'll actually start to target individuals about signing up for health insurance. And I dare say you won't hear a lot about the penalty. You're going to hear a lot about the importance of signing up for health insurance, because that's really the message we want to deliver. Why it's important for you as a father, you as a student, you as a mother, why it's important for your children to have health care, why it's important to have preventive health, why it's important to see a doctor early, diseases that can be prevented. Because as I remind everyone, chronic disease is still the #1 cost problem for us all. So anything we can do to prevent that's going to be helpful. So effective October 1, as an individual, I can go on healthcare.gov and I can put in my zip code. And if I'm in a state that's got a state-based exchange, it will immediately refer me to the state-based exchange, and I'll work the plans there. In the case of Georgia, we will continue to provide that information. So let's say I'm a resident of Georgia, and I go in. What happens is I will fill out an automated application, and it will ping different hubs, it's called Federal Hub, but it will ping different information. So it will tell me if I'm eligible for a tax credit. It also in the background is checking to see if you're a citizen, because this is only available to citizens of the country. It will also check Social Security to make sure you are who you say you are. And then it will tell you what you're eligible for in terms of a tax credit. And then it will refer you to a group of plans that are available, say in Atlanta. And you'll be able to look. If I'm an individual who wants a silver, gold, bronze plan, I'll be able to look and see what it will cost me each month. And I'll be able to sign up for insurance there. If I'm not comfortable doing that, because all of us are not tech savvy, then there is a 1-800 number that will be available 24/7. There will have individuals who can walk you through a manual application if you're more comfortable with that, perfectly an automated application. But we'll also refer you to individuals in Atlanta or whatever part of Georgia or the country you're in who can help you if you need in-person assistance to help you sign up. The open enrollment period actually goes from October 1 through March 31st. So it's a 6-month period where we'll be trying to get individuals to sign up for health insurance. So you'll see all this unfold. It will start on time. I'm not worried about it starting on time. Will we have to make changes as we go along? Absolutely. But I think it's a really exciting time. And I guess what I would just say is for someone who's been in healthcare now 40 years, we've talked about this for 30 or 40 years. How do we get an access? How do we get a quality? How do we get a cost? And this may not be the perfect plan, but it is a plan, and it's a plan that's going forward. And it will only be successful if I have the help and support of folks like you in the room, and I look forward to working with each other. So thank you.